Good morning, everyone. I'm presenting a case on diagnostic dilemma of orbital cellulitis. A 3-year-old male patient presented in IOPD with chief complaint of severe eye pain in right eye. It was associated with lid swelling and inability to open the eyes. Patient presented with assured skin on the affected area with underlying necrotic tissue. His parents gave the history of foreign body in right eye 3 days ago. He was taken to local hospital. No insect or any other foreign body was seen. He was treated for lid swelling with topical antibiotic and anti-inflammatory treatment. His condition got worsened and he was not able to open his eye on presentation in ROPD. On examination, vision of the right eye cannot be assessed. In the left eye also it cannot be assessed as the patient was 3 years old. Extraocular movements cannot be assessed. In the lids, necros skin of lid was present, and left eye was lids, conjunctiva, cornea, iris, anterior chamber orbit within the normal limit. On contrast enhanced MRI, a small T1, T2 hypointense focus in the upper lid was present, query foreign body, swelling of right preseptal and perizygomatic soft tissue with fat stranding, no obvious intracranial extension of collection, high TLC count, rest was within normal limit, and so plan of management was examination under anesthesia. Patient was taken into OT under short GA, eye examination was done, and to our surprise an insect was extracted from the lower fornix. Voriconazole wash was done, debridement of scarred and necrosed tissue from lids were done. Insect was sent for microbiological examination. It was found out to be Tachyporus obtusus. On examination, superficial corneal haze was present. Infiltrates were present inferiorly. Circumcorneal congestion was present. He was treated with lubricants, topical steroids, and Natamet, Vigamox, and eye ointment Penthagel. And IV antibiotics, vancomycin and ceftriaxone was also started. This was a picture of the post-op day 1, day 2 and day 3. It was great to see the patient's sunshine smiles on the day 2 post-op. 1 week post-op, the healing process of the scar tissue was complicated by the presence of membrane. And 2 weeks post-op, the patient demonstrated a favorable healing response with no evidence of membrane. On examination, vision in the right eye was 612 and left eye was 66. Inferior bands of infiltrates were present. 2 weeks post-operatively, the patient demonstrated a favorable healing response with no evidence of membrane. On examination, right eye 612 and inferior bands were present. We are happy to report that the patient's orbital cellulitis was fully resolved at 3 weeks and with follow-up vision of 6.6 in the right eye. So take-home message is examination under anesthesia is a necessary diagnostic tool for uncooperative patients, enabling us to conduct a thorough assessment. This case underscores the need for timely recognition and treatment to prevent the onset of orbital cellulitis and its associated complications. Thank you.
Thank you, Dr.